Oh, Daisy go first. Okay. Because it is also Colorectal Cancer Awareness Month as well. So, Odacy is a nurse practitioner, right? Am I right?
Yes.
Okay.
Hmm.
And her specialty is colorectal cancer. Well, colorectal is a colorectal practice. Let me put it like that. It's a practice. So, Odacy, I will be quiet and I will give you the floor.
Okay, well, good evening, everybody. So I will just give you guys some information that's from the CDC. So this is information that you can find online, and then thereafter, if there's anything that you want to ask me, in particular, specific, to my practice, then I'll be more than happy to answer. I work at Houston Methodist in the Neo Cancer Center. I've been in oncology for over 10 years, but specifically with GI or colorectal for about 5 years now. So I am a doctor of nursing practice, nurse practitioner at Houston Methodist. And again, just take some notes, or if you have any questions, just let me know. We'll start with just the basic information of colorectal cancer is a leading cause of cancer death in the United States. It is the fourth most common cancer in men and women in the United States. Breast cancer is number one, number two, prostate, and number three, lung. So this is a very prevalent cancer, and it's one of the cancers right along with prostate too that is often found in late stages. And it's more so because of the screening is not done until later. But we'll get a little bit more into that. So, what is colorectal cancer? It's a disease in which the colon and the rectum grow out of control. And sometimes there are abnormal growths known as polyps that form in the colon and rectum. And sometimes the polyps can be cancerous. But we'll talk about a little bit more about polyps in a few minutes and how to test for that. So in short, colorectal cancer is just what we call a GI cancer. Any thing from your stomach, small intestine, large intestine to your rectum as well. We also look at pancreatic and gallbladder cancers as well when we're talking about GI cancers, but we'll stick with colorectal because that's the month. Um, so when you're looking at the colorectal cancer, what are some risk factors? So the older that you get, that's a risk factor. Regular exercise should be one of the things that we are doing. So if you are not having a proper diet or not getting exercise, and I like to tell my patients, just physical activity is based on what your level of activity could be for each person because it's different. At least 30 minutes at the minimum of walking is acceptable. Aerobics, swimming, things like that is also considered exercise. When we're talking about healthy weight and diet, of course, it's fruits, vegetables, your lean meats, your chicken. Now, beef is one of those things that we try to stay away from, steaks and things like that. So just your chicken, your fish, and your vegetables and your fruits. Now, fruits, we have to be mindful because they are of natural sugar. So when we're talking about our patients with diabetes, those things have to be considered as well. But those are some of the things that help reduce your risk. We can't change age, but we can change our activity, our diet, and our weight. You may also have the risk factor of, as you get older, what we call inflammatory bowel disease, which is just what we would ideally call an inflamed colon. And the two most chronic inflammatory bowel diseases are Crohn's and ulcerative colitis. And sometimes it's just noted as just an irritable bowel disease. And with this, it's characterized as just inflammation of your GI tract. And prolonged inflammation of the GI tract does damage. So that's one of the risk factors as well. A personal family history of colon cancer or colorectal polyps. There's also genetic syndromes that are noted. Just again, Lynch syndrome is what's noted, but you can have that tested with genetic testing as well to find out if that is a symptom. We talked about the lifestyle factors and risk. Like I said, exercise, your fruits and vegetables, low fiber and high fat diets, overweight, obesity, alcohol, and tobacco use. When we're talking about screenings, so screenings is one of the things that you would do would be called a colonoscopy. And typically the colonoscopies are done at the age of 45. Now, it's a little different because it's based on insurance. So ideally, 45 is your common age. But what I've noticed in practice is that we have patients that are under 45. Some are in the 30s for colorectal, but I've seen younger with different types of GI cancers. So one of the things is if you're visiting your primary care doctor and you feel like you have some of these risks associated or some of the symptoms, one of the things is I always tell patients is to be an advocate for your care. Now, the insurance is going to hit you over the head and tell you that it's probably thousands of dollars. They're not paying for your colonoscopy. But if you have a physician that is willing to work with you, they can code it a certain way. Okay, I have a friend and a coworker. He's 30, probably 36 at the time. He did have irritable bowel disease, and his physician was able to code it properly for him to get that tested. Again, he's not 45, but the testing was done. So again, 45 is your routine age to have your colonoscopy done or your colorectal screening done. And what happens is that you will have a light sedative for most patients, and there is a thin, slender tube. Well, first, let's go back. You'll have a colon prep. That we'll start there. A not so pleasant colon prep of go lightly, and it'll clear out your bowel. So that way, when they do go looking with a scope, the thin tube that they will use in the colonoscopy will be used to view a visual picture of what's going on inside of your rectum up into your colon. And this is where the polyp comes in at. Now, if you have a polyp, which I tell patients is just kind of like a little blip, a little small, but I don't want to say nodule because nodules are sometimes used as cancerous words, but it's a small little bump, so say, that they will clip off and they will send it off to pathology to tell you if it's cancerous or not. Okay. Now, polyps are not uncommon. They're frequent depending on your diet and your history. And the polyp will be still sent off to the laboratory. If it comes back cancerous, then that's a different discussion that you'll have with your primary doctor. And then that's where I would come in my physician as well. Now, with your screenings, having that done, polyps are precancerous. They're not a cancerous diagnosis. But that's one of the things that you will do if you use your entire colon. You can also have a flexible sigmoid. This test is done in the doctor's office as well. The tube is put into your rectum and it checks for polyps as well, but it does not check the entire colon. It just checks the rectum and the lower third of the colon. And that's done every 5 or every 10 years. And back to the colonoscopy, if everything is normal based on your history, it can be done every 10 years, but sooner, just depending on the patient. Also, there's one thing called a stool test. You may have heard of a Guide test or a fecal occult blood test, where you take a sample of your stool and you'll put it onto either a smear kit or into a tube, and then it just tests to see if there's any blood in your stool. There's also a FIT DNA test, where this test collects a sample of your stool to look for DNA in your stool as well. And there's a FIT test, another FIT test called a fecal immunochemical test, and it uses the antibodies to detect blood in the stool as well. So those are the 3 screening methods: your colonoscopy, your sigmoidoscopy, and your stool test that you do use. And again, the Colonoscopy is done every 10 years for most patients, and the sigmoid is every 5 or 10 years. And the guaiac stool samples can be done whenever there's a suspiciousness for either a GI issue or cancer. Now, and again, the recommended screenings begin at age 45. But again, this is where you have to be an advocate and speak with your physician to discuss if there's any underlying conditions to see if, things need to be done a little sooner. Same thing with breast cancer patients. If you have a family history, you would get screened earlier. And sometimes you just have to be an advocate and get those things done as well. So those are the coverages of the colorectal screening, your testing, and some recommendations on being healthy to kind of prevent those risk factors other than genetics. Are there any questions?
I have a comment. Daisy, thank
Okay.
you so much. I had a precancerous polyp at age 32.
Mm-hmm.
And I've always had something different than everybody else. I was never the regular person, no matter what I ate. But as I got older, it got worse.
Mm-hmm.
So I was having some issues, and I did see my GI doctor. And just like you said, I had to do the colonoscopy. They found the precancerous polyp, and I had to see him again in 5 years,
Mm-hmm.
not 10. So I know now with my children, because I had it at 32, my son is 30. Um, like you said, it's all about family history, things like that. I know that all my children need to get screened earlier. But my precancerous, like I said, I went back in 5, everything was good. I was pushed out to 7, then I was pushed out to 10. So I know that my children have to be screened earlier. Is that mark going to be 35 or would it be 40? What would it be for my children?
Okay, so the first thing I would recommend is having a good PCP is the
Mhm.
very first step, because we
Okay.
have a lot of physicians that are not so hands-on, you know what I mean? Like they'll get you in and get you out.
Right.
So finding a good primary care doctor is key, because a lot of times with insurances, you cannot just get a GI doctor.
Right.
So you have to go through the referral process. So having a good primary doctor first, if you have to be referred to a GI, they can do it as well, because some physicians are nice enough to say, this is not my thing, this is not my specialty. Let me refer you to a GI doctor who can do a little bit more testing.
Right.
So no, even at 32 or early 30s, noting that in your family history when you go and see your primary doctor. Now, we should all be seeing a physician at least once a year for a yearly physical, blood work, and so forth. Now, when you're seeing this physician, I would recommend your son saying, hey, I have a family history of polyps.
Right.
I don't have any symptoms, because a lot of times you don't have any symptoms
Right.
until it's too late. And that's where we're seeing a lot of the late staging of the diagnosis of stage 3 to 4 cancers,
Right.
because a lot of them don't have a lot of symptoms.
Right.
And I would let him know that, to let the physician know that.
Right.
And if he's one, I always tell patients and people, look at your stool, because a lot of people don't.
Right.
They don't. You don't look in, you don't know if it's a different color. You're not gonna know if it's loose or watery by not looking at what it looks like in the water.
Right.
You have to pay attention to your bowel patterns and the changes. Okay. Now you do have some people that are just prone to constipation. So Metamucil is something you can take every day.
That's
You
it.
can do Miralax, and that's something every day that you can use. Those are light things that do not cause any harsh side effects, that can get you to go every day or every other day. Like I tell people, stool softeners are only to make your stool soft, not to make you go.
That's
Okay. So also be cautious with laxatives, because our bodies are designed to do what it's supposed to do on its own, but sometimes you need a little bit more help. So drinking plenty of water, eating your vegetables, cooked vegetables at that. will help keep your GI system stimulated. So just letting your GI doctor know that, hey, I have this family history of colon cancer or polyps. So that way they can do the necessary testing. Sometimes you may have to go and get a screening or do a fecal testing a little sooner than others. And that's how you can stay abreast of those things.
That's the one thing that I have noticed about these the children that were raised with vegetables. When they
Mm-hmm.
get out on their own, they don't consider that something that they need.
Mm-hmm.
And I think it's just kind of unfortunate because like I said, I was 32, but that was in 2000. You
Mm-hmm.
know, that the things are so different now, but diet and smoking, like you said, smoking, and the kids,
Vaping, because a
they
lot of these
vape,
kids
they
don't smoke,
hookah,
they
and they
vape.
don't understand
Mm-hmm.
that's still smoking. Just because
Correct.
it's in a cute place and you have these little cute tips and everything, it's still smoke. And insurances are knowing, they're asking you, do you smoke or do you vape? And
Right.
if you do not tell the truth, you're putting your coverage at risk. So there's no benign anything. There's no
Right.
benign hookah. There's no benign marijuana. There's
Right.
always a risk. And so I'm big about diet. I'm big about, like you said, fresh fruits, fresh vegetables. But I think our young people, because they have so many choices, that's not the first thing that they're going to go to, like you said, until it's too late.
Mm-hmm.
I still think about the young man, Chadwick Boseman,
Mm-hmm.
who had colon cancer, fit as a
Mm-hmm.
fiddle, but we
Yeah.
don't know, his lifestyle or genetics and things like that. But, when he found out, I know it was too late. It was too
Right.
late. And that is something that we must be aware of. Okay. So, but yes, and then I guess the other thing is when you're older, when you're say over 75,
Mm-hmm.
they don't use colonoscopies for the elderly because fear of poking a hole or
Right.
perforation of the colon. Do those patients still get screened another way, or we just say, well, you've gotten to this stage, we're good to go?
So that goes back to what? So it's kind of funny because a lot of times the older people feel like, look, I'm 80 years old. I don't want to go through this. I'm just not bothered by it.
Right.
However, again, you should still be seeing a geriatric because I had to recommend that to my grandmother. And so she didn't even know what that was. And so she just had a regular PCP. And I was like, well, you need a geriatric
Right.
physician. And she was like, what is that? I said, well, this physician specifically deals with the older population.
Right.
And that's a specialty.
Right.
And so she saw this particular physician, and it's different. It was day and night compared to a regular PCP.
Right.
And so I would still recommend that you go to do your yearly exams. Now, ideally, even with mammograms, because they cut those off, even for older women, even your pap smears.
That's
Okay.
true. That is true.
I right now have a coworker. We had to work her mother-in-law in, and I want to say she's 75 or 6, somewhere around that age. We don't do pap smears for that age,
Right.
right?
Right.
So ideally, she was like, well, why would I be getting it done? It's not recommended. The
Right.
CDC, the Task Prevention Force, does not recommend a almost 80-year-old woman to have a pap smear or a mammogram and things of that nature. So how would she have known? And I said, well, these are the things that we have to be mindful of. And she had no symptoms, no spotting, no anything that would
Right.
have made her feel that something was wrong, until she started having this abdominal pain. But of course, now we're talking about stage 3
My Lord.
ovarian cancer because I, didn't get screened because I didn't need to. So these are the things that we are looking at as healthcare professionals and researchers to say, okay, well, this is the limit that the government is putting on healthcare as to what they will cover, what they won't, or what the recommendations are. So I even now with myself, because you're supposed to get a pap smear done, and if it's normal for the last 2 or 3 years, then you can go every 2 years.
That's right.
I advise against it because you never know what can happen within a year. So again, regular visits, if you're older than the recommended age of 75, screenings are not required or mandatory. However, you can request them.
Yes, the doctor, my mom's doctor, and my mom is 85, says you need a mammogram. And so
Correct.
I appreciate her doctor, but she's a woman of color. So,
Correct.
you know, she is more sympathetic
Mhm.
to what happens in our bodies. So yes, you know, if it's not, and you know, there's no positive history of breast cancer, but we do have prostate cancer in the family.
Mhm.
So that's why we must get that done. So thank you very much. I
You might
appreciate
let me. Can I ask a question? I don't know. I was maybe leaving from the truck to my computer. Did you say how well can you trust those Cologuards, those tests that you do yourself? Are they?
Now, as time has gone on, they've said they've improved.
they have.
They have improved.
Mhm.
Um, so if I feel like this, if you are uncertain as a patient, if you've done a Cologuard and you feel like, okay, it's fine, I would still do regular checkups. Like I said, you have to be an advocate for your care because your doctor's not gonna. I don't call my patients and say, "Hey, how you doing? How things going?" No, you have to tell me what's going on and follow up with me because I won't see you. Well, I deal with cancer patients, so I see them frequently. But my patients that are no cancer, I tell them I'll see you in 3 to 6 months. But you have to check in with me to tell me if anything has changed. Okay,
Right.
so again, looking at your stool. Okay. Do you have hemorrhoids? Do you know what a hemorrhoid is? Do you know that you can have internal hemorrhoids? Some of them are a little deeper. Are you watching for constipation to know that you can strain and have some blood? But are you monitoring that every bowel movement to make sure that this is just a one time occurrence, but nothing frequent? And if you are unsure, it's nothing wrong with going to the physician and saying, hey, just want to be sure. I had a couple of episodes of some blood loss.